Hi, my name is Natalia Chavez. I am from Group 5, and today I'm going to present the bonus assignment. Today I'm going to talk about thyroid surgery. I believe it is a quite common surgery that a lot of people know about, and also it is part of my main topics of research that I'm doing right now. I chose this article that is titled Randomized Clinical Trial of Platysma Muscle Suture versus No Suture for Wound Closure After Thyroid Surgery. These are the authors. And this article was published in 2017 in the British Journal of Surgery. So, for a brief introduction, as I said before, the thyroid surgery is a very common surgery. More than 150,000 surgeries are performed in the US per year. If you are part of the surgery world or head and neck, you know that one of the biggest doubts that surgeons have while going into the thyroid is whether or not to close up the platysma muscle. When you want to go into the thyroid, you have to cut into the platysma muscle, which is this muscle over here that is all over the neck. And some surgeons decide to put a suture and close the muscle or just leave it open. So there's no current publications or any reviews of whether or not there's a difference between patients that are receiving a closed suture of the platysma or patients that are just leaving open the muscle. So this group of surgeons decided to conduct a clinical trial to see if there's a difference between closing the platysma muscle or just leaving the incision wound open. So the methods, it is a randomized controlled trial. It is patient blinded. I'm going to discuss further on why it's only patient blinded. Patients were assigned either to a platysma suture group versus a no platysma suture. We need to keep in mind that this is the independent variable and it is categorical. And also they conducted a follow-up of 6 months. A total of 119 patients were eligible for the study. 32 did not meet the inclusion criteria, 3 declined to participate, and 2 were not able to become part of the study because of organizational failure. And so a total of 82 patients were randomized into the two groups. There were no loss to follow-up, and a total of 41 patients in each group. So as I said before, it was only patient blinded. We need to keep in mind that for it to be double blinded, it is almost impossible in surgery trials because surgeons cannot be blinded. Surgeons will know if they're closing or not the platysma, since they are the ones who are conducting the surgery and they're the ones who are performing the sutures. So it is very difficult to blind the surgeons. It's almost impossible basically. So it's only patient blinded. The randomization was used using an online software, and they used block randomization in groups of 10 patients. This is also very important because, as we can see in table 1, we can also prove that it was a block randomization since both groups are evenly distributed and they each have 41 patients. So we can prove that it was a block randomization. And also, the allocation concealment was successful. The patients did not know whether they received an opened wound for the platysma or it was sutured up. So the primary outcome was wound-specific post-op pain 24 hours after surgery, which was assessed with a VAS pain scale. This scale it goes by from 0 to 10. This is the dependent variable, which is a continuous variable. It is very important to clarify that the VAS pain scale can either be used as a continuous variable or as an ordinal variable. If you decide to use it, like for example, from 0 to 3, it's low pain, from 4 to 5, it's moderate, and from 5 to 10 is high pain, it is obviously an ordinal variable. But in this case, this study, they decided to use this scale as a continuous variable. This is very important for the statistical analysis that I'm going to discuss further on. But it is very important to clarify if the VAS pain scale is going to be used as an ordinal variable or as a continuous variable. Other secondary outcomes are the VAS at 6 hours on day 2, on day 14, the duration of the surgery, and post-op analgesia consumption. Also, the authors recorded if there was a presence of seroma, of hematoma, the infection rate of the patients, if there was any disorders of the functional anatomy, and also the cosmetic part of the cervical scar. So for the statistical analysis, as we know, we need to calculate the sample size. They calculate a total sample size of 41 subjects per group. They use an effect size of a minimum difference of 1 unit on the 10-point VAS scale. They wanted a 90% power and a p or alpha less than 0.05 in a two-sided test. They used two distinct tests. They used the Mett-Whitney-U test, which is, they use a continuous variable, as I said before, which is the VAS pain scale, with a non-normal distribution. They did not specify why it was a non-normal distribution. I guess we need to remember that they can use a histogram, they can measure the skewness, the kurtosis, they can graph it, they can use plenty of tests to see if it is normally distributed or not. And so it was pretty clear that they used that it was a non-normal distribution since they used a non-parametric test, which is the Mann-Whitney-U test. And additionally, they used the chi-square and the Fisher's exact test for the variables that are nominal, which are two categories that I'm gonna also explain further on. So this is what I use to clear my mind about the statistical analysis and which one to use for which trial, for which different types of variables. So the first question that I ask myself is the type of data categorical or continuous? So if it is continuous, then I ask myself the second question, which is, does it have a normal or non-normal distribution? If it has a non-normal distribution, which we know that we can measure this using a histogram, the skewness, the kurtosis, etc. If we have a non-normal distribution, we have two options. We can either use a non-parametric test that I'm going to explain further on, or we can transform the data. Well, when we transform the data, our data will completely become normally distributed. And if we have a normal distribution of our data, we can use a parametric test, which is the t-test, which is paired or unpaired, ANOVA, linear regression, and for association, we can use the Pearson correlation. We need to keep in mind that the parametric tests, they are both valid and they're very powerful. So this is like the ideal situation, but we know that this cannot be used all the time for each variable. So when we have a non-normal distribution or we are using an ordinal variable, we can use the non-parametric test. These tests, we need to keep in mind that they are very valid since they're not making any assumptions, but they're not as powerful as the parametric tests. But when we have to use them, because we're either with a non-normal distribution or a categorical or ordinal variable, these are the tests that can be used, which are the Mann-Whitney, the Wilkinson sign rank, the Kruskal-Wallis, the Friedman test, or for any association, we can use the Spearman correlation. Also, as I said before, the chi-square or the Fisher's exact tests are used for nominal data. So in our case, since we are presented with a continuous variable but it has a non-normal distribution, we use the Mann-Whitney-U test and we use the chi-square and Fisher's exact test. Here in our table, it's very clear that only two variables were statistically significant different. So here we can see with a p-value of 0.025, which is less than 0.05, 6 hours after surgery, the VAS score for patients with a platysma suture was 3.15 compared to 2.17 with a no platysma suture. So we can conclude that there was a less pain in this group in the no platysma suture than in the platysma suture 6 hours after surgery, that it is statistically significant. The same we can conclude with 24 hours after surgery, because the platysma suture group had a 3.15 scale in the VAS compared to a 2.17 in the no platysma suture group, and it also has a p-value of 0.02. So we can also conclude that it is a statistically significant difference between these two groups. But as we can see, there are no other p-values or variables that are statistically significant between these two groups. And additionally, I would like to point out that these variables use the Mann-Whitney test, but these are the two variables that use the chi-square, because we can see that it is a yes or no question. Let's say need for post-op rescue operates, yes or no, 3 and 2. And the same with the wound-specific complication. Do we have a seroma or hematoma? Yes or no. Is there a wound infection? Yes or no. So for these types of variables, we can use the chi-square. It is very important to have that in mind as well. Okay, so for the discussion, we can conclude that there's significantly less wound-specific pain in the initial post-op period, which is after 6 hours and after 24 hours. There's no difference in long-term cosmetic results of the cervical scar. And also there's no difference in post-op wound complications, which are the infections and the hematoma or seroma. The authors also clarified that there are limitations to this study. There's no sufficient power to detect minor differences in the POSAS score, which is the cosmetic. So there's an increased risk for a type 2 error in this part of the study. So basically, the general conclusion of this study is that suturing the platysmal muscle during wound closure following thyroid surgery can be omitted. It is basically up to the surgeon whether they want to close the platysmal muscle or not. There's basically no difference. The only difference that was detected was less pain after 6 hours and after 24 hours in both groups. Thank you very much. This is my beautiful city, Bogota, Colombia, and I hope you enjoyed this article.